thinking that now we're going to be using carfilzomib, pomalidomide, daratumumab, dexamethasone at relapse. Okay, that sounds like where we're going here. We're going to have incredibly high response rate, probably, I would guess, over half of people entering complete remission, even in relapse. Tell us about MRD monitoring, and do you stop treatment based on that? If you get MRD negativity after, let's say, a year of treatment, do you keep going or do you just stop, Ola?
So in our practice, we check for MRD status in every patient who reaches CR. We have that as a model across the whole program. We do not
just for what, because I think if I'm a community oncologist, where do I send a sample? How do I get this done?
Well, so for the flow cytometry, you certainly need to set up your program so you can do it right. And I think the Spanish model, the Euroflow, is the most well published, but there are other alternative models out there also. So that includes panels with a series of antibodies.
Is it available commercially anywhere, or is this something you have to get done in academic?
It is published, and labs that run flow cytometry panels can implement that, and everything is available in the literature. So I think it's more a matter of having the lab calibrating the way of doing the flow. For the molecular testing for right now, the provider out in California, Adapt Immune, they offer the clonocyte testing.
And that's a send-out test?
That's a send-out test for sequencing.
So do you, when you get it and it comes back negative,
right?
Are you using that as a decision point to stop, or you don't trust it enough?
At this point, we do not use it as a decision point to stop. But as I told you before, for newly diagnosed patients, if you are MRD negative to the deepest degree, we have this conversation that we are unsure whether the upfront delivery of melphalan is going to add PFS.
I guess I'm troubled by this notion that you just treat for ever. I mean, what does that mean? Is it 5 years, 10 years? Well, at some point, you have to say enough is enough, or is this CML where you treat for life?
Well, so I can tell you what we're doing in our research program at our institution. It's interesting to hear what other people are doing here at the table. So at our institution, we do 5 years of follow-up, and we do MRD testing longitudinally. And if you have maintained MRD for 5 years, which no one so far has done on this program, but the intent is to bring up the question, do you want to go off maintenance or not? And we will continue monitoring to just see what the data tells us. We don't know right now.
Rafael, are you using MRD monitoring?
I am, and I think there's a human aspect of this which is so important, because I have tested patients who have been on long-term maintenance approaches or chronic therapy with lenalidomide, where I propose that we do MRD to make a decision. And the test is the easy part. What's hard is the discussion. And so the patient is going to ask me, can you assure me that this is good enough? And I say, I don't know. It's very appealing. I think how I would use it is if the patient is burdened by the symptoms from maintenance, maybe I would push more for that and say, let's consider it stopping, what we did before without MRD. But if the patient is tolerating it well, then it's sometimes a hard sell, because they say, I don't know, it's working well for me. Why do I want to do changes?
I must admit, I have used it as a stopping point that people on lenalidomide, they've got some chronic fatigue, a little bit of diarrhea, come back MRD negative after 2 or 3 years of maintenance. I have used that as a criteria for discontinuing. Anybody
Keith,
else?
does that change based on this meta-analysis saying that you have an overall survival advantage?
No, I don't think so. I think it's, to me, getting into MRD negativity is the point, and once you're there.
So have you followed MRD over time? Do you see?
No, because we've only started using it in the last 6 months, so we're just beginning.
I think that's the next question, obviously. You need
the plan would be to bring them back and repeat it in 6 months and reinitiate therapy if we saw positive.
But there's a lot of applications. I'll give you an example. A patient with high-risk disease where we did a bone marrow 1 year out, MRD negative. I was quick to get on the phone and tell that person, guess what, we're in the right. We're not changing anything, but that's quite useful for a person that knows that they had high-risk disease, and now -17, mind you, and now the patient is MRD negative by the NGS.
If I recall correctly, the CML data, chronic myeloid leukemia, show that if you reach MRD negativity and you maintain it for about 2 years, if you go off therapy, half patients have no relapse, and half do.
The other half do.
And the other half do, but we can retreat them down to MRD negativity again. So I think that's the data we need to generate for myeloma.
Any other thoughts before we move on to new drugs?
I'd agree.